Good morning, good afternoon, good evening, depending on where you're joining us. We would like to welcome you all to this room AD10 for this special site event, which is addressing something which is always forgotten in mainstream programming, and this is fungal diseases. Fungal disease is a major cause of morbidity and mortality in the world, and Africa is not an exception. At-risk patients include HIV, those with cancers, and many other patients. However, in Africa, where two-thirds of the cancer population, two-thirds of the HIV population is found, diagnosis and treatment of fungal disease is still a big problem. Among the first 5 causes of mortality in HIV, we already have 3 of them which are caused by fungal infections. And I'm sure that if we push the diagnosis of fungal infections in HIV, we may see that maybe all 5 first causes of mortality in this population is due to fungal infections. So in order to decrease the mortality associated with HIV in Africa, we need to diagnose and treat fungal infections. We cannot talk about doing this without, first of all, doing a situational analysis. So we are here tonight to share the results of a comprehensive situational analysis of the diagnostic and treatment capacity of fungal infections in Africa, which was done by GAFFI in 48 out of 55 member states in Africa. Today, this report, which was the initial findings of this, were used by Africa CDC and GAFFI to do regional consultations with stakeholders in ministries of health to ensure that, first of all, this data represents what is found in the country, and also to discuss about how this information could be used to drive change and ameliorate the quality of life of the patients who are affected by this. This report, after this consultation, was drafted. It is at a stage which we can share with you. So we are really glad, because today is a special day that we are addressing this problem on the African continent using African data, such that together we can launch this report, discuss, debate, and choose action points based on what we think is feasible and pragmatic. At Africa CDC, we always say, talk is good, but talk with action is better. So by the time we leave this room, we should have some action points on which we can start working tomorrow to make sure that we decrease mortality associated with fungal diseases. I wouldn't take much of your time. It's going to be an interesting evening, and our program is very straightforward. We will first of all have a welcome remark by Dr. Mohammed, who is the head of division of disease control and prevention at Africa CDC. Then we'll have some welcome remarks by Dr. Pakeret of Madagascar Ministry of Health. Then we'll have to share a short presentation with you so that you get to understand the methodology of how this survey was carried out. Then we'll tell you about the validation workshop that we did with the initial findings of the data, after which we will do a brief summary of fungal diseases. What are the opportunities that we could harness? Then GAFFI had done a similar thing in Southern America, but that time it was operational research to put in place something that can drive change. And they will be sharing with us that experience tonight. After which we will do an African case study of capacity building. Then will come the cream of the cake, where we're going to have a panel discussion to see how we can synthesize the data, what we have shared together, and define action points. After which we will do summary of what we've learned. Then we will officially launch the report. And I want to say, those of us who are in this room today, we are privileged to have the first copies of this report that just came out of printing. And I can tell you, David just picked them up at the reception now, coming straight from customs. So, we are privileged to have this report, to participate in this discussion, so we should be part of the action and part of the solution. Thank you very much. Dr. Mohammed.
Good evening, ladies and gentlemen. And to those on the online, maybe it's morning, maybe it's afternoon. We wish you also a very good time of the day that you are in. Elvis said something very interesting here. He said, talk is good, but talk and action is better. So when we talk about fungal infection, I'm one of those whom I would say at the very beginning of my career, no, even before the beginning, as a medical student at about the turn of the century, that was when HIV was, we were expecting the worst, and we were very young medical students following our professors during ward rounds, and all the medical wards were filled with patients living with HIV. Interestingly, the only medication we could give them then was, if I can remember, I'm a neuropsychiatrist, so I left the clinical medicine for clinical neuropsychiatry, but I think, was it amphotericin B? It was so expensive that only 1% of the patients on the world could afford it. We're not talking about affording the HIV medication because it was not even available then. Was it AZT? And I remember then you could get it with 50,000 naira, which is equivalent to 5 months' salary of most of the patients on the ward. And one thing that struck me, one day we were taking clinical history, and the patient said he's having pain on swallowing. And my professor turned around and looked at me and asked me, what do you think is this? What did I even say? Is it odonophagia or something like that? Then what do you think is responsible? And I was stuck. Then he said, can you ask the patient to open his mouth? And the patient opened his mouth. I think that was my first week of clinical posting. And what I saw, I never forget. Because when we were kids, when we throw bed under the bed, then it starts smelling, then you pull it out, you see growths of fungal mold all over the place. It was like that. Vivid oral thrush. I was seeing it for the first time. So, I've never forgotten that half of the patients in that ward do die because of fungal infection. Another clinical experience, still as a student, we did lumbar puncture, we did everything, the CSF was clear, nothing we did not do, but the patient was still having frank symptom of meningitis. Who has meningitis without clouded CSF? Sorry for those who are not, I'm using some very serious medical terms here. It can't be meningitis. This patient may be faking it or something. Then one of the professors said, can we just try to give the patient antifungal? I can't remember the antifungal that was. Is ketoconazole or something? I can't remember. And a few days, or maybe a week later, the patient got better. Then we started talking. He said, most likely, because the lab in one of the biggest teaching hospitals in Nigeria where I trained does not have a single, or the ability to diagnose or to test for fungal infection. So they did it just blindly, and the patient got better. So he started telling us it could be histoplasmosis or cryptococcus neoformans, fungal meningitis. The patient, I remember, was discharged. He got better. So for me, those are the days when the formative years of my life as a clinician. Then I abandoned clinical nursing and got into public health. In my first year in Africa CDC, we toured 6 labs, national reference labs on the continent. I'm not going to mention them because the result was not good. In all of those labs, we saw a functional virology section, a functional bacteriology section with virologists and bacteriologists, but none has a functional mycology or a fungal. So I asked myself, with all the improvement between 2000 at the turn of the century, 1999, and now, 2017, Africa CDC was just 1 year old then. There was absolutely no improvement in the area of fungal infection, in the detection of fungal infection. So it means 70% or more, this is my anecdotal figure, of fungal infection are still being treated blindly, just like it was done during my days. So when Nafiisah and Elvis came to me and said, we want to work with an institution that's working on fungal infection, I didn't think twice. It falls squarely within what Nafiisah is doing. And I know, as somebody who has tested both sides, the clinical aspect and now public health, you don't go to ministers of health or especially ministers of finance without evidence, without hardcore evidence. You're wasting your time. And I remember then when we used to ask questions as young medical students and young doctors, we were told that the evidence for mycology, for fungal infection, is very poor or non-existent because there is a gap in capacity. There is a gap in, what do people call it? The facilities for diagnosis. And shortly after I left, that's when Cphia brought in so many things. I think there was a marked improvement in the virology section. We could do viral load, all available. Most of the labs could do culture for bacteria or something. I'm not sure fungal infection had that privilege. So it is with great pleasure that today I'm here to welcome everybody to a side event that is going to discuss a very important work that has been done for 2 years by GAFFI, the kind of evidence that we will need and require to continue to push very hard for improvement across the whole health system when it comes to fungal infection. I tell you today, I had a division where we have non-communicable diseases, injuries, and mental health. Of course, the endemic and neglected tropical diseases, and community health workers, and reproductive health. And in my years of clinical practice, I've seen where cancer patients on what they call that? Chemotherapy, thank you. You know, I'm forgetting all these things. Public health is making me really lose touch with clinical medicine. Dying because of fungal infection. If you've examined the cervix of a woman with CA cervix, most of them, they have florid fungal infection. And I'm worried. In those days, we know it was amphotericin B, ketoconazole. I don't know. That's why I'm looking forward to reading this report, whether we've developed newer antifungal agent. How are we doing with the resistance to the old ones we're using? Could that patient have survived if you give him today amphotericin B or ketoconazole? How are we doing with detection? Do we need to wait until they come with florid oral thrush? Or do we need to wait until it has spread across the blood-brain barrier to the CSF? And then we will struggle with the diagnosis. Most of us, young doctors, if you don't see a clouded CSF, you will say, no, this is not meningitis. But fungal infection doesn't give you that. So all of these are areas that we can continue to work with institutions like GAFFI to ensure that we improve the lot of the continent when it comes to the health systems for prevention and control of fungal infection. Africa CDC has what we call the new public health order, which among 4 or 5, is working with trusted and respectful, but she always reminded me, respectful, action-oriented partners. And I think GAFFI is one of them. We know that at the time the head of state gave us the mandate to deliver, to continue to work to get the continent to deliver on the Agenda 2063 health, Africa, we want the health components. We could and cannot do it alone. We have to work with partners. We have to work with partners to ensure local manufacturing of health consumables. How many of the current antifungals are being produced on the continent? When there's another pandemic that locks down the continent or locks down the global logistics, the continent will have to wait for antifungal to be shipped in from India or other parts of the world. How do we bridge that workforce gap that has been in existence since so many years back when I was a medical student? And the professor used to casually say, we do not have expertise in mycology. How do we ensure this expertise is available, at least at the national level, and cascaded down to the subnational level on the continent? How do we ensure that we are able to use the excellent reports that we have here to influence what the director of Africa CDC, his decisions in how to support member states? How do we ensure that our member states, when they are taking decision on funding for health, they fund that component that deals with prevention and control of fungal diseases? How do we ensure that if our reference labs do not have the capacity to make a diagnosis of fungal infection, you can be sure that there's no lab that will be able to make that diagnosis? How do we change this narrative? this is what should be coming out from this report, from this data that we've gathered. But again, data get obsolete very quickly. So how do we set up a system that will continue to update this data, that will continue to get us more and more up-to-date reports that we can use to talk to our principals and say, we need this investment in the area of fungal health system. Thank you, colleagues. We will listen very carefully to what is being discussed, and I'm looking forward to the reports of this meeting, not just the signing, but how we will intend to answer all these questions that we've talked about and have meaningful impact in our member state. Thank you.
Merci pour la parole et permettez-moi de vous parler en français. Mesdames et messieurs, distingués invités ici présents, tout protocole observé, tous les participants qui nous rejoignent en ligne en ce moment, bonsoir et bienvenue. Je profite de l'opportunité qui m'est offerte pour remercier Africa CDC pour l'invitation adressée au ministre de la Santé de Madagascar, qui malheureusement n'a pas pu venir à cet important événement, mais qui m'a chargé de vous transmettre à vous toutes ces salutations. Mesdames et messieurs, distingués invités, c'est un réel plaisir pour moi de participer à cet événement parallèle de la deuxième conférence sur la santé publique en Afrique. Étant donné que c'est une occasion pour nous de nous pencher sur les maladies touchant nos frères et sœurs africains, longtemps ignorés malgré leurs effets dévastateurs. Le rapport qui est lancé ce jour est le fruit d'un travail titanesque à l'échelle de l'Afrique tout entière, car il est le fruit de la collaboration de 47 États membres, dont Madagascar. Nos experts dans le domaine de la mycologie, de la dermatologie, de l'infection au VIH-Sida, de la tuberculose et beaucoup d'autres domaines, tout ceci dans le cadre du travail de GAFFI et d'Africa CDC. Bon nombre de ces experts sont présents dans cette salle et nous vous félicitons vraiment pour le résultat obtenu. Vous pouvez en être fiers. Pour Madagascar, le professeur Lalasuave Naramarjatovu, professeur de dermatologie à la faculté de médecine d'Antananarivo, et ses collègues ont travaillé sans relâche pour un diagnostic correct et un traitement adéquat des maladies fongiques endémiques telles que la chromoblastomycose et la sporotrichose. Il ne s'agit que d'un début, car le gros du travail nous attend. Nous pouvons avancer tenant compte des disponibilités et lacunes en matière de diagnostic et de traitement dans le cadre continental de l'Union africaine sur les maladies tropicales négligées. Nous devons donc utiliser ces documents clés et collaborer avec tous les partenaires pour nous assurer que nous répondons aux besoins critiques de tous les États membres. Cette collaboration est essentielle pour que les erreurs ne soient refaites et que les acquis puissent être consolidés. L'Africa CDC sera pour nous tous un partenaire pour améliorer la santé publique en Afrique et nous vous remercions donc pour ce que vous avez fait, mais surtout pour ce que vous allez faire dans ce domaine. En somme, mesdames et messieurs, distingués invités, je vous remercie une fois de plus d'avoir pris le temps d'être parmi nous aujourd'hui et je nous souhaite des délibérations fructueuses ce soir. Merci.
My name is David Denning, and I'm going to tell you how we developed the survey. I'm going to ask you to go to the next slide, please. So just as a couple of background pieces of information, we estimate that there are around 13 million people at risk every day of dying of a fungal infection. These are people with leukemia, lung cancer, HIV/AIDS, bad TB, bad asthma, and we think there are around 2 million deaths. But the documentation is very poor because diagnostics are not available in many places. And nearly 50% of HIV deaths are probably due to fungal disease. It's difficult to document for sure, but that is about the figure. Next slide. The WHO recently issued a fungal pathogen priority list, and they went through, did a large number of systematic surveys, which was supported by the University of Sydney, and this followed the tradition that they had used for bacterial, and their particular reason for doing this was because of problems of antifungal resistance and clinical failure of medicine. And this was well tweeted and really well seen across the world. Next slide. So what GAFFI is trying to do is that we would like to see a world free of death and suffering caused by fungal disease. It's difficult to be sure that this will occur because many of these fungi live on our skin or in the air. But we're particularly interested in health systems in low and middle income countries to improve the ability to diagnose and treat fungal disease. And as a minimum step, we believe that the WHO essential diagnostics and the WHO essential medicines should be available for everybody. Next slide. We have worked with many countries and individuals and centers in Africa. So here are some examples, and there are actually many others, working on cryptococcal antigen testing in Nigeria, Mali, the Gambia, the Aspergillus antibody testing for chronic pulmonary aspergillosis, which I won't go into today, but it looks like TB, and histoplasmosis, which is a complication of HIV. So we have, and in the room today, and you will hear from some of the people that we've been working with on this. And we've also done a lot of work on what the burden of fungal disease is as well. Next slide. So the burden work has been published for 26 different countries, more than 100 different authors from Africa. We've also published 68 other research papers and reviews on numerous different topics from 10 countries. And GAFFI and our GAFFI ambassador group have presented many talks and teaching sessions across the continent. Next slide. So what GAFFI is trying to do, and the way it's working, is to work as a very lean central organization. So we have a very small executive team, and much of the work is done on a volunteer basis. So for example, all of the work that I've done for GAFFI is unfunded. It's partly funded by the University of Manchester and my time, for example. Economically, we're interested in economically sustainable solutions. We do not believe that gifts from PEPFAR, Global Fund, etc. forever are the right answer. We believe in sustainable solutions. We also believe that we should be working with countries through existing structures. We shouldn't be trying to develop a whole new system for approaching this fungal disease. We need to work within what is there already. And we want to employ any project or funding that we get through local resources as much as we possibly can. Next slide. So now we come to the report, and I hope you all have a copy of it. It has been translated into French as well. Thank you to Nafiisah, who did a very large amount of this work. French is the only language I speak a little bit of, so we were able to do this together and finish it. And it's online, and you will be able to see it on the GAFFI website, and you can download it now from the GAFFI website. Next slide. This work was led through GAFFI by Emma Orefuwa, who is currently waiting for a plane to bring her from Nairobi. She's been in transit for nearly 48 hours as a result of a trip. So she is very sorry to be here, not to be here, and she did an awful lot of the work on this report. Next slide. The WHO essential diagnostics include cryptoantigen and then cultures, direct microscopy and histopathology. In 2019, we added histoplasma antigen to that, which was particularly relevant for Southeast Asia and Latin America, and as you'll hear, increasingly important in Africa. And then last year, we added Aspergillus antigen for invasive aspergillosis aspira's antibody for chronic pulmonary aspergillosis, and pneumocystis PCR. So this is the primary focus of the report, but in addition, we've collected data on procedures and imaging as well. Next slide. So the way that the report was delivered to the centers is on the right-hand side. You can see the spreadsheet that was completed, and there are three parts: the lab diagnostics, clinical procedures, including skin biopsy, lumbar puncture, spirometry, bronchoscopy, and corneal scraping, and then imaging, and also whether radiologists were available to read those images, because some of these images are fairly complex. And we also collected information on what level of hospital was undertaking these tests, whether it was available in the private or public sector, how often the tests were done, which was a function of three things: whether clinicians asked for the test, whether the patient could afford to pay for it, and whether the lab could do it. So this is a function of multiple things. And then we collected information about who pays for healthcare. Next slide. So there were multiple steps in this, including the questionnaire development, which was piloted, completion within country, and there was no individual in a country who could answer all these questions. You know, somebody in the lab wouldn't know about radiology, somebody wouldn't know about what happened in dermatology services. So there was a necessary snowballing approach to bring data in from multiple sources within each country. That data was reviewed. We then had a video conference with every individual that had reported that, and sometimes their colleagues as well. We gathered additional information from literature, from companies that were selling tests. We did a video conference with most of the countries, but not all of them, with country leaders, but different people that had filled in the questionnaire, although they were part of the Congress, to try and validate it. And then finally, Africa CDC did another round of validation, which Nafiisah will tell you about. And this over here tells you, the map tells you where the levels of response that we got prior to the Africa CDC engagement with, in terms of the additional webinars and additional information that we got. Next slide. So this is our group of GAFFI ambassadors. Some of them are here. Some would have been here if they'd been able to get away. The respondents to the survey, there were 72 key individuals who did that, many of them laboratory professionals, but others were physicians or pathologists or center directors. We had additional information from 11 people subsequently, and then a very large number of people who came in afterwards who spoke with, who contributed to the survey which the Africa CDC did. Next slide. So our basic tenet is that we want to leave no one behind. Too many people don't have access to life-saving diagnostics and antifungal drugs. It's not our focus today on the drugs, but that's another problem which will need to be addressed. And we really do need to change that. And we're delighted that you're here today and contributing to this. Thank you very much.
Thank you very much, David, for that comprehensive presentation. Now we're going to give the floor to Nafiisah, who is going to take us through the validation and consultative process that we did at Africa CDC. So Nafiisah is a technical officer and program lead of endemic diseases and neglected tropical diseases at Africa CDC. Over to you, Nafiisah.
I'm just going to give an overview of the virtual consultations that we did to further validate the data that was collected by GAFFI. And I'll go very quickly through this because I want to give a lot of time for discussion and obviously questions from the audience. So just to give an overview, as Africa CDC, as you know, we divide the continent into 5 regions. It's just easier to manage, and it makes sense in terms of, priorities that you're looking at. So we've got the North, the South, the East, the West, and Central Africa. So we had 5 virtual consultations that we conducted, really sending out, invitations to experts from different areas of work, definitely through the ministries of health, because that's where we really wanted the key validation to come from. Looking at, CSOs, mycology experts, dermatologists, experts, working on HIV/AIDS, TB, etc. So really trying to get a wide range, even NTD experts looking at a wide range of expertise to really look at the data critically and say, you know, this reflects what's going on in the country. And I think that was also important, really looking at multi-institutional experts, so that, you know, when someone is looking at the data, it's not just from one institution in Tunisia or one institution, you know, in Gambia or Sierra Leone. It's really looking at, you know, experts from across the board, so that the data can really, when we look at the data in the report today, we can say this reflects, you know, the reality across the country. So the main findings, so again, I'll just talk about, you know, very briefly about this, because I think this will come out very clearly in the discussion, in the panels that we will have later. So I don't want to give too much away right now, but really to look at what was interesting, I think mostly for me really, is to see that, you know, there were a lot of overlapping issues. So in a way, you know, this is good for us, because it means that when we are addressing these issues, there is a common way in which we can address them, whether it's looking at workforce development, whether it's looking at, you know, local manufacturing or increasing access to diagnostics. The issues were really, you know, very much overlapping and very similar in the regions. Of course, there were some specificities. I won't go into details, but we can discuss those obviously in the panel later. And I also want to, no, you have to go back, sorry. Very quickly, I want to highlight, Dr. Mohammed mentioned it, the new public health order. Yeah, at Africa CDC, which looks at these 5 different pillars that you see on the screen here. And really, you know, these are where, you know, we really see, this is our vision for the continent. This is our vision to make the continent more sustainable in terms of addressing her public health needs and making sure that, you know, we really are independent and autonomous in the way we address these diseases. And this is just looking at having a strengthened, you know, healthcare workforce, strengthen African health institutions, and that includes your regulatory institutions, such as the African Medicines Agency, that is looking at harmonizing regulations across the continent, so that when medicines are introduced, they don't have to be, you know, revalidated, you know, approved at country level, which takes a lot of time, as we know. Looking at increased domestic funding and pool procurement. So now we can go to the next slide. Oh, okay. Okay, so very quickly here again, some of the key things that came out was that, you know, we need to train our healthcare workforce to identify the patients at highest risk, and that's across the board, across the continuum of care. Across, you know, so starting, you know, from your clinician that's looking at your patients to really understand the symptoms when looking at the patients, all the way to obviously, and not just looking at the patients and knowing what symptoms to look for, but also knowing what samples to collect to send to the lab, right? That's also a key thing. And also now looking at your lab technicians, making sure that they are trained to do the test properly, whether it's microscopy or, you know, whatever the case is. And also one of the things that we looked at was how do we decentralize this even further? And one of the things that came out was, you know, the possibility of using community healthcare workers, both to raise awareness and perhaps even to conduct some point of care testing, just like it's been done, you know, with malaria, right? Next slide, please. So, okay, looking at this pillar of pool procurement and local manufacturing, the idea is that, you know, in the short term, we can't do everything at once. In the short term, what would be great is if, at a minimum, all teaching and referral hospitals would acquire diagnostics according to what's on the WHO essential diagnostic list, and these are some examples of those tests. But now, if you, I said short term, but if we say medium term even, leveraging on how we can look at bulk procurement of some of these assays, some of these POCTs, some of these drugs that already exist for these diseases that are just not accessible because we don't have enough evidence to show that, you know, so there's no demand because there's no evidence, and so it's a cycle. It just feeds into each of the. But in the short term, how can we leverage existing platforms? And Africa CDC has what we call the AMSP platform, the African Medical Supplies Platform, that has been used quite successfully during COVID-19. So how do we leverage these platforms for bulk procurement of such assays and such, you know, drugs that can then, you know, be disseminated to, can be affordable to our 55 member states. But we're thinking long term as well. So as much as, you know, in the short term, yes, we're looking at how to bulk purchase, you know, these items. How can we ensure that we are manufacturing them on the continent itself. And this is where, we're really working with different initiatives that came up during COVID, but really trying to increase the reach of these initiatives, the PAVM and the AFCAD for increasing diagnostics on the continent. And what we think also would be interesting is that as we are talking about the African Continental Free Trade Area, as we're talking about these, these continental initiatives that are taking place, how are we going to leverage on those to ensure that we have a continental distribution of these diagnostics that are being manufactured, of these drugs that are going to be manufactured on the continent, making them accessible to all African countries. Next slide, please. Increase domestic, so this is a big one. I think, this is something that we all talk about. And it's interesting that this is a key thing that comes out for every disease. This is not just specific for fungal diseases. It's across the board. We need more domestic financing. We need more independence and autonomy in terms of how we're funding our programs. And that, really calls for honoring some of these endorsements that have been made at head of state level. The Abuja Declaration, calling not only for allocation of 15% of the annual budget to health, but also calling for ensuring the availability of drugs at affordable prices and technologies for treatment, care, and prevention of HIV/AIDS, TB, and other infectious diseases. So this is a key thing, that's in the Abuja Declaration, and this is something that we need to be working on and advocating with our heads of states to ensure that they uphold these endorsements that they have made, these commitments that they have made. Also harnessing the public-private partnerships for health financing so that really we can give universal healthcare coverage to all patients, and we can give these services free of charge to all our patients. And in terms of the Africa CDC support, so this is something that we'll talk a bit about later, but Dr. Mohammed touched on this briefly when he said, ministries of health, when you look at, if you come and you show them burden of disease, that is one thing. When you show, but we have to take this data even further. We have to be able to build investment cases and say, if you invest 50 million today, you will save 100 million in 5 years. This is the kind of numbers that make them think, oh, we should really look at this. Because we must never forget that we are in competition with a lot of other diseases, a lot of other priorities. This is a priority, but so are the other things. So how do we ensure that we also get a fair share of the budget when we are discussing with our leaders back home? Next slide, please. And yes, strengthen African health institutions. So I've spoken about enforcing capacities of the drug regulation agencies to ensure harmonization of the regulatory systems, really increasing research, and I think Elvis will agree with me, we don't have enough research being conducted on the continent in this area. We don't have enough clinical trials being conducted, but I think even when clinical trials are being conducted, we don't have a fair share of the end product being available even in the country where the trials were conducted. So this is something that really has to change. We really have to be able to negotiate better and really ensure that we, I don't want to say demand, but yes, we demand what is rightfully ours. And yes, I think I just want to also touch very quickly on the issue of integration. And I think that's where, this is something that we're trying to do at Africa CDC. As much as, I work on HIV, AIDS, TB, malaria, etc., it's all well and good. But what we're trying to do is really develop a sort of strategy internally to understand how can we integrate our support to member states for all these diseases, which is a huge endeavor. But as you've seen, all these issues that are being raised for fungal diseases are the same things that are being raised for other diseases. Yes, there are some specificities for fungal diseases, we agree. But how do we ensure that we are integrating all these efforts? And this is where, we also want to see, and I think, David, you said it very well, the work that GAFFI is doing, you use, what is already existing. And that is exactly what we're trying to do as well. How do we leverage on existing surveillance systems and strengthen them so that they can also address fungal diseases as a priority? Next one. So this is, I think, my last slide. And this is, I think, one of the most important ones. One of the pillars, or the key pillars of the new public health order is the respectful action-oriented partnership. So it's respectful because we know, and that's why we work hand in hand with partners who've been in this area of work for a very long time, and GAFFI, like GAFFI. but it's also action-oriented. So it means that as much as, the partnership, is based on trust, yes, but it's also based on action. So we come together and we work together to make sure that at the end of the day, we are developing some concrete action points. And I hope really, like for the discussion today, there will be some concrete action points that come out that we can, in the short, medium, and long term, address. That we won't be able to do everything at once, but we just need to identify some key priorities that we can work on together. Yeah, so I think that's it for me. Yes, thank you. Thank you very much.
Right now, I would call on 3 panelists who are going to do a very rapid overview on fungal diseases, and what are the opportunities here. So I'll invite Rita, and I'll also invite Felix Bongomin, as well as Martha, because they are going to talk without transition. You're welcome, Dr. Rita Oladele.
So we shall be presenting a summary of the survey findings of diagnostics for fungal diseases in Africa. Next slide. So one of the most important group of fungal diseases are really fungal diseases occurring in HIV, advanced HIV disease, and that includes several fungal diseases, including cryptococcal meningitis, pneumocystis pneumonia, disseminated histoplasmosis, esophageal candidiasis, but also ringworm and other fungal skin problems. We have already highlighted that there are some really very important essential diagnostic tests for fungal diseases and also procedures. So for example, we note that cryptococcal antigen test is really very key for diagnosis of cryptococcal meningitis, and so is sputum and bronchoscopy for pneumocystis pneumonia, urine antigen test and bone marrow biopsy for disseminated histoplasmosis, and then endoscopy and fungal culture as well for esophageal candidiasis. Next slide. So from the survey, which has just been concluded and Prof. Denning has highlighted, you can see clearly that highlighted in orange is really countries which do not have some of these essential diagnostics. So for this case, we are highlighting the cryptococcal antigen test, which is key for diagnosis of cryptococcal meningitis. So you can see that most countries actually do not have cryptococcal antigen test being publicly available. And that translates into over 613 million people who would benefit from this test actually not having access to this, with the exception being mainly in Southern Africa, but also other parts of Northern Africa, where at least some of these tests are being done often in public sector and some few as well in the private sector. So we still have a lot of gaps as far as access to cryptococcal antigen test is concerned in Africa. Next slide. Then GAFFI has developed a cryptococcal meningitis dashboard for each of the African countries as well following this survey. And you can be able to follow in your, for your specific countries as well and see across the 3 domains. And that is diagnostic test, availability of diagnostic test, treatment, but also availability of country-specific guidelines for management of cryptococcal meningitis. So looking at one of 2 examples, one, Zambia, you can see that they have availability of lumbar puncture that is often published, often performed, and they also have a national cryptococcal meningitis treatment guideline, which was published in 2018. But you find that, for example, flucytosine is not registered and is also not available in these countries. So in a score of 10, they only score about 5. And this could be compared with another country, for example, Cameroon, where lumbar puncture is only performed occasionally in most of its facilities. Flucytosine is not available, but also looking at the country-specific guideline for cryptococcal meningitis, it also doesn't exist. So for all of us here, we can be looking at each of our countries and see what are their capabilities as far as diagnosis and management of cryptococcal meningitis is concerned. Thank you.
Thank you. So as far as fungal infections is concerned, the fungus spores. They are found everywhere in the environment. And we should remember that almost 70% of HIV-infected individuals are in Africa. So they are still exposed to these fungal spores, and they are at risk of developing fungal infections. And then when you are looking at lung fungal infections, these include chronic pulmonary fungi, the chronic pulmonary aspergillosis. This is the leading one, which is clinically comparable to pulmonary tuberculosis and mimic pulmonary tuberculosis in everything when it comes to the clinical diagnosis. Include fungal asthma, which is in rise in Africa with the biodiversity change all over the world, including Africa. So fungal asthma is also in increase. And the diagnosis of these conditions, the lung fungal infections, include the simple chest X-ray, but sometimes it might need to go to the CT scan, but blood aspergillus antibody test, which is a rapid test, a point of care test that can be done even in a simple lower health facilities, and fungal culture of sputum culture. But it can also go to the complex lung fungal diagnosis, include bronchoscopy, which it's a bit complicated, but if the clinicians are there, it can be done. And then with bronchoscopy, we can get the sample, clinical samples, which can be done microscopy. You can do direct microscopy from the lump that you have been brought from the bronchoscopy, and then you can do fungal culture from the sample that you obtained. But when it comes to fungal asthma infections, spirometry can easily be done. Skin allergy test and immunoglobulin, these are among the tests which can be done to diagnose the fungal. Next slide. So when you look at the survey that we conducted, you can just see that up to 54% of the countries in Africa, they have capacity to do fungal culture. In the public and as in the public sectors, it's 46%, only 46% of the countries, and these are the green ones that have ability to do fungal culture for the diagnosis of fungal infections. But we are still having 8 countries in Africa which they don't have capacity to do fungal culture for diagnosis of fungal infections, include these lung fungal infection. Next slide, please.
So fungal keratitis is a neglected tropical disease. It's a disease that affects the poor, in that it's mostly people in the agrarian community that are at risk. One of the major risk factors for fungal keratitis is trauma, okay? And these are people that are in their productive ages. So fungal keratitis, to make a diagnosis of it, we need corneal scraping, because corneal blindness is the 4th leading cause of blindness. So you need to do that early enough. So corneal scraping, direct microscopy on the scrapings, then fungal cultures and identification of these organisms. And then we need antifungal eye drops, okay? WHO recommends nitromycin. The issue is how available is it in country, on the continent. So when you look at it, you can see from this data that it is rarely available, just a couple of countries within the African continent, despite the fact that the African continent has a large agrarian community. So we have people that are going blind unnecessarily because this is treatable, okay? So there's no data in a number of other countries about the availability of this eye drop. Okay, I can speak for my country. It's not licensed. A couple of people do have it, but it's not licensed in country. And I'm sure that's why there's no data across most of these African countries, because it's not licensed. The next slide, please. So when you look at corneal scraping, which is the first step to making this diagnosis and preventing blindness, you will see that it's never done in 13 countries in public setting, 26 in private settings, and that is a whole 11% There's 116 million people that would have benefited from these services are being denied it. Not because we don't know, we don't have the skill set, yes, but we have the ability to achieve it because as a continent, we can come together to decide that we are determined to move this forward. So when you look at provision of cornea scraping across Africa, the data is pretty alarming because this is something that should be available throughout the whole of Africa, and it's not available. Thank you.
I'll again remind you that Africa, in Africa, 80% of Africans were dependent on agriculture. That's our basic activity that we are doing. And fungal spores are found in the soil. And as we are doing our agricultural activities, we can easily get these fungal spores through injuries through the agricultural activities. And among the skin fungal infections and includes the ringworms, which are present in 20 to 30% of Africa. If I talk to my country in Tanzania, 23% of children and the school-going children of 10 years to 14 years have these ringworm infections led by Tinea capitis. And then we have the WHO have included some of the skin fungal infections to the neglected tropical diseases, and these are also in some of the African countries. And the diagnosis of these skin fungal infections, and including neglected tropical diseases, it's a simple microscopy by using either skin scrap or getting a skin tissues, and then you do potassium hydroxide preparation, a simple potassium hydroxide preparations by high power field, and then you can easily see if this is fungal infections and you manage the patient. But if you get the tissue, then you can do also histological staining, but you can also do fungal culture from this skin scrap that you got from the diseased person. Next slide, please. So when you look at the survey that we did in Africa, you can see that it's only 44% of the country where they can do a simple microscopy for diagnosis of skin fungal infection, just potassium hydroxide preparation microscopy. And when you go to the private sector, it's only 27% of the countries in Africa where they can do that, a simple microscopy for diagnosis of skin fungal infections. And this accounts for 51% of the population. So we have like 49% of the populations that they are not often diagnosed with skin fungal infection, and yet the skin fungal infections, they are there in Africa. We have like 8 countries, you can see them in orange, where they don't have that access at all, and they're still in Africa. Thank you.
And finally, we are talking about fungal infections occurring in among patients with cancer, particularly hematological malignancies, but also in the intensive care unit, especially that we have seen an increased number of ICU patients as well due to COVID-19. But also now Africa is seeing several cases of hematological malignancies and other forms of cancers. So several fungal infections occur in the ICU, but also in patients with hematological malignancies. And this includes Candida bloodstream infection, Candida peritonitis, invasive aspergillosis, importantly, and also pneumocystis, Giarrovecchii pneumonia. So next slide. So in the survey, we looked at Aspergillus antigen test, typically galactomannan, which is a key test for diagnosis of invasive aspergillosis. And you can see that really only 4% of the countries which have been surveyed have or routinely do Aspergillus antigen test. And that is also a similar proportion is seen in the private sector. So you can see that largely over 80%, both in public and about 77% in the private sector really do not have access, or they never do Aspergillus antigen test. And that means about 1 billion people who should have access actually Aspergillus antigen test are currently not able to access really this very important test for diagnosis of invasive aspergillosis in Africa. Thank you.
So we've heard about fungal infections, and I think Felix mentioned something. COVID-19 associated aspergillosis. Fungal infections have been associated with HIV since the beginning. And now we are talking about a new in quotes infection, COVID, and we see fungal infections being associated to that. It means that for us to be good clinicians, we should always think fungus. At Africa CDC, we believe in learning from each other, learning from others. And interestingly, GAFFI has got an experience in Southern America, which we'd like to share with you, so that maybe in our discussion, we may see how some lessons learned from there can be applied in our context.
So we've got two examples, if you like, of what we've been trying to do. One of them is outside the continent, and one of them, Rita will speak, in the continent. Next slide. So we're very interested in health systems. You know, you can't just introduce a test and expect it to solve the problem. You've got to have the whole system operating. And we published in 2017 a summary of how fungal disease and health systems work together. And that document and the meeting that we held in Lima is for South America, Central America, is there for you to think about. So it's a health system approach. Next slide. So our question in Guatemala was, if we improve diagnostics for HIV patients, can we reduce deaths? Okay, it's a simple question, but difficult to answer, because what's the baseline? How do you do the diagnostics? How do you integrate all of that to make a difference? But that was the question. And we worked with an NGO in Guatemala City, ASI, and they implemented this with our support. Next slide. So we wanted to demonstrate this because nobody has done this on a public health basis. We do diagnostic evaluations and we show sensitivity, specificity, but you don't integrate this into and show a significant public health benefit. And that was our objective. And we knew that the WHO had recommended that all patients, who particularly advanced HIV patients, look for opportunistic infection. So that was what we approached it. Next slide. So in Guatemala at that time, they've got a smallish population of HIV patients, so a total at that time of about 46,000, but quite a lot of deaths every year, 1,600 deaths. And the ARV coverage was only 19%, so really quite a low coverage. Next slide. And if you look at the curves over time, you can see that the number of patients is rising, the deaths was rising steeply, and there was not much improvement in ART coverage over time. And many of the Latin American countries have poor ART coverage. Next slide. So in this program, we looked at new cases who had abandoned ART and coming back for care, and people who were sick on ARVs and weren't doing well. And we screened them. So this was a screening approach. We did not rely on the doctor thinking, oh, I wonder if it's this disease. Oh, I wonder if it's this disease. We said, these patients are at risk, we will screen them. And we did that regardless of the CD4 cell count, and then we followed them for 6 months. And there were 3 cohorts, about 6,000 patients included. So a big population study. Next slide. So Dr. Eduardo Arathun is an infectious disease physician who leads this NGO, and they have a very good laboratory in Guatemala City. And he was one of these 13 centers that contributed to this program, and he led the training, the clinical training, and he led the evaluation of the results. Next slide. And we did direct microscopy for fungi and TB. We did fungal cultures on respiratory or other specimens. We did an isolator blood culture specifically for histoplasmosis. We did PCR for TB and histo. We did CRAG, cryptococcal antigen detection, in serum and then spinal fluid if that was sent. And we also added histoplasma antigen. And Guatemala has a very high rate of histoplasmosis. There's a lot of people exposed to this fungus in the environment. And we published this paper, and you can look it up and see the results of the comparisons here. Next slide. There was an online ordering service. So that the physicians in all these different centers could order online, and the lab knew that the sample was coming. There was a courier service, there was a mobile phone alert for positive results, and then the results were delivered online. So the IT component was very important, and the courier service was very important. And then there was the lab as well. Next slide. And they held annual workshops, they did trainings, they did online training, Zoom training, case discussions online, and then there was an e-learning package as well. So there was a lot of education as well as the system that was set up. Next slide. So the request came in by internet, the courier delivered the sample, the tests were done, a CRAG test and direct smears were delivered the same day service. The histoplasma antigen was within 24 hours. The PCRs for TB and histo were within 3 days. And if cultures were negative, and sometimes they were, it took a long time to report a negative. So these are rapid turnaround time tests, and this is really important in these patients with severe disease. Next slide. The drugs didn't change through the whole program. There was no change at all. They don't have liposomal amphotericin, they don't have flucytosine, they don't have voriconazole. So they were dependent on TB drugs, amphotericin, fluconazole, flucytosine, and itraconazole. Next slide. And next slide. And these are the results of the new patients. Okay, so histoplasmosis was the most common infection. 18% of these patients had a life-threatening infection with one of these pathogens, and which is a lot of patients. Next slide. And if you look at the CD4 cell counts, below 100, you can see that histoplasmosis was particularly common in patients with very low CD4 cell counts, and so was Cryptococcus. But actually, there were infections way up beyond 200, even up to 350. Next slide. And then if you look also, you'll see that 8% of the patients had co-infections. So if we took a diagnostic approach and the doctor, oh, I wonder if it's this infection, I wonder if that infection, probably some of these co-infections would get missed. Next slide. And the outcomes were quite good. 30-day mortality was only 20%. You'd expect the mortality to be about 95%. So this is a big reduction. When you get to 6 months, the mortality's gone up to about 30%. But this is still a big, big improvement. Next slide. And when you look at change over time of all of these patients, you can see that the blue bar shows increasing numbers of diagnoses being made. So there's more training, more familiarity, better results, and the whole system is working better. There's more data coming in, more results are made, and the mortality has gone down from nearly 25% to about 16%. So this is an 8% reduction in mortality. This has never been demonstrated before on a public health basis. This is the first time that diagnostics alone, with nothing else changed, has shown a significant fall in mortality. And that's an 8% fall in effectively 2 years. Next slide. And you can see also the diagnoses went up, and the numbers of diagnoses of histoplasmosis went up. So again, it was this learning and improving over time, which was very important. Next slide. So the benefit here is commercial techniques were used. There was an in-house PCR, but otherwise it was commercial. It was cost effective. In fact, this was not an expensive program, in fact, at all. And it required a lot of human training, human resources, and some automation. Next slide. It was allowed continuous education of the healthcare workers. There was a big network development, and that produced a community of high quality practitioners, which was really helpful for other diseases as well. And also QC and proficiency testing for the laboratories. Next slide. And it adds value to the country. So now new drugs are being brought into the country because they can see the value of doing that. The pharma and diagnostic companies are more interested in the country, and that's growing. And they've got a lot of data for epidemiology, surveillance, and implementation research, so that it's a data surveillance benefit as well to the country. Next slide. So to summarize, 2,000 patients, 21% or so had a life-threatening infection. mortality went down from overall from 34% to 27%, with 54% dying in the first month. And so getting in there quickly is really important. TB diagnoses went down, but the survival went up. And that was because of misdiagnosis of TB. So patients were assumed to have TB, treated for TB, but it was the wrong diagnosis, so they died. But when you actually make a diagnosis of TB, you can show benefit. And histoplasmosis mortality also fell by over 10% over those 2 years. And now, successfully, the program has been adopted by the ministry, and they're now driving it, and they've taken it on. And that is a fantastic product in our terms. Next slide. So those are the papers. You can look them all up, and they're there. Next slide. And again, leave no one behind. Thank you.
If it can be done in South America, it can be done in Africa. I strongly believe that. And we are the ones to do it. No one will do it for us. So at this point, we just want to see how a simple action using a very pragmatic approach can make a difference. So I'd like to invite Dr. Rita Oladele to share the Nigerian experience on how capacity building can improve diagnosis and management of cryptococcal meningitis.
Our focus here was on the advanced HIV disease population because we were able to, from data, it shows, you can see that the numbers, that were initiating ART were increasing. They stopped working. But the deaths plateaued. So what was causing the plateau of the deaths? Because we all know that once they are able to access treatment, they should get better, we should have less death, but death has plateaued. And the question is why? The next slide, please. And in exploring why this stagnation of mortality, a number of things have been suggested. A lot of patients will have delayed HIV diagnosis. They are presenting late to care now. There's delayed enrollment in care, so there's delay in ART initiation. And then as a continent, we are very religious, so we do seek other treatment modalities till when it's too late and then come back. And then patients abandoning care, and then they are lost to follow up, then they come back to care when they are very bad with advanced HIV disease. And then there's treatment failure due to non-adherence and drug resistance, and then the non-availability of treatment for opportunistic infections. And all these have been alluded to contribute to HIV disease progression and advanced HIV disease. The next slide, please. So these opportunistic infections, leading there is TB, and then you have cryptococcal meningitis, you have toxoplasmosis, pneumocystis, and then several other little ones in there, and we're going to show some more data on that. The next slide. So why do we not diagnose serious fungal infections in Africa and other resource-limited settings? Why don't we? And that is because there's really lack of knowledge, poor awareness on the part of healthcare workers. About 5 years ago, we did a survey where we looked at about 1,045 doctors. Wanted to know how many of them had knowledge of invasive fungal infections, these life-threatening diseases. And only 2% had fair knowledge, 0.2% had good knowledge. Interestingly enough, 5 years later, after plenty of trainings and intervention, it has improved. We repeated the survey this year, and we discovered it's now 10% of doctors. Yeah. And we thought we had done well, but 10% is appalling, isn't it? Yeah. So, and then the other thing is that we have lack of laboratory infrastructure. Even if the doctors had that index of suspicion, the technical know-how is not available in the lab. The diagnostics are not available in the lab. So there's that gap. Even if the doctor had that index of suspicion, he still cannot confirm a diagnosis. So that leads to poor, so it ends up being a vicious circle, right? The doctor doesn't have the index of suspicion because it's not something he commonly sees. And fungal infections don't carry a signboard and say, I'm fungal. So the next slide, please. And then, next, please. I'm sure you've seen this table, this figure everywhere, right? Raja's work showing the burden of the disease of cryptococcal antigenemia. And as you can see that my country is supposed, Nigeria is supposed to be supposed to have high burden of it. But interestingly enough, as of when this paper was published, our National Data Repository had not one single documented case of cryptococcal meningitis. The next slide. So I always say this, I said, we pretend to be ostriches. You see the ostrich, very big body, and as long as he cannot see the danger, he's convinced that it doesn't exist. So that was the way we treated cryptococcal meningitis in our country for a long time. Next slide, please. So Nigeria has the 4th highest HIV burden in the world. We have a prevalence of 1.4%, that's about 2 million people. The number on treatment is 1.9 currently. Interestingly enough, we just recently found out that 42% of our patients that are newly enrolled into care have advanced HIV disease, which is a beautiful at-risk population for opportunistic fungal infections. And at the national level, we are not collecting data on mortality, and which is something that must change, because we need to know who is dying and what they are dying from. Next slide, please. So this is showing where we are. Like I said, it's the same thing that it is globally. Our deaths have stagnated. They are meant to be going down, despite the fact that uptake into treatment, ART initiation is on the increase, but deaths have stagnated. Next slide, please. So I will pause here and I will tell a story, because I discovered something: nobody forgets stories. About 5 years ago, there was a professor in my facility. She was on the obese side. She presented, she had this complaint of having headaches, and also she was treated for malaria. I'm sure she started treatment on her own initially. And then she wasn't getting any better. She ended up being admitted in the high dependency care unit, and they made a diagnosis of encephalitis. They went ahead to do a lumbar puncture, and the labs reported that they saw numerous lymphocytes. Okay? And based on that, a diagnosis of query viral encephalitis, because GeneXpert was negative, was made. However, her clinical condition deteriorated and she became unconscious. She ended up in the ICU. It was at that point I got to know about the case, and I went in there. I was like, let's do the crack test. They said no. She's been a widow for over 30 years. So I said it doesn't matter. So we did the crack test, and for the first time, we ended up, in less than 2 minutes, it was positive. Okay, we ended up going back, the CSF, because the CSF, the lymphocytes were cryptococcals. And when we did the Indian ink, it picked the capsule. But for the unskilled or the unknowledgeable, in quote, all they see were these large, non-nucleated cells. They were lymphocytes. So I now asked them to do a CD4 count, and interestingly enough, a CD4 count came out as 4. As of then, we had no amphotericin B in country. We started her on fluconazole, and she died 3 days later. With all the knowledge, she had like about 4 PhD students on ground that we had to find other people to supervise. The next slide. So that's brought to mind that there was a need for training. Because if we do not train, people will not know. Okay, so to raise that index of suspicion, we needed to tell stories like this. We needed to take us back to medical school days. And then we needed to work on getting these drugs, the diagnostics and the drugs on ground. And we needed to include screening for cryptococcal meningitis in our HIV program. Interestingly enough, as of then, it was in our guidelines. I remember the page, I think it was page 42 or 52. Preemptive, screen for crack screening and preemptive therapy. And not one single facility in country was doing that. And then we needed also to identify the difference in the management of TB meningitis and cryptococcal meningitis, because they do appear almost the same when you look at the facts that they will present clinically almost the same. And then clinicians needed to understand the role of therapeutic lumbar puncture in the management of cryptococcal meningitis, because we discovered that was a skill set that was lacking in country. They do lumbar puncture in children in the pediatric group, but everybody avoids doing it in the adult population. Next slide, please. So we did this training with support from CDC Foundation across 13 sites in Nigeria, in partnership with Cphia, okay, and then GAFFI, we used training models from, the models were developed by GAFFI Live, and then CDC provided technical support on it. And then we did hands-on training for the crack test and lumbar puncture. And then in 6 months, we recorded 250 cases for a country that never had any prior to that. Next slide, please. So these were some of the training activities in the different sites. You could see that we got a mannequin for people to practice hands-on for the LP, because it was a skill set that disappeared. Okay, and then we had lots of focus group discussions. But the beautiful thing from this training was the fact that out of it, we were able to say this problem does exist, and the country adopted it, and the country went ahead to set up a technical working group for advanced HIV disease. And as I speak to you, my country routinely now screens for cryptococcal meningitis all patients that have advanced HIV disease, okay? And so it's a marked improvement. And interestingly enough, she didn't die in vain, at least it amounted for something. And the diagnostics are available. We do have the therapeutics available now also. Next slide, please. So these were the outcomes. I've already discussed this. The fact that we set up a technical working group. We had advocacy, plenty of meetings, step-down trainings. I think that's part of why we got up to 10%. Okay, next slide, please. So I told that very sad story before, right? Yes, and then this was the second story after the treatment, after the trainings. A doctor was able to see a patient and say, I think this is advanced HIV disease, because the patient came for treatment, came into care, was HIV positive, and initially before in country, we just go ahead, start ART. Patient came down with iris, cryptococcal meningitis, but because we knew what to do, just with therapeutic lumbar puncture alone, this patient did very well. Okay, because that pressure was brought down, and then we treated, although the patient got blind initially, but 6 months later, he recovered sight back. Next slide, please. So the next problem we looked at was because this is a very vulnerable population. We're targeting low-hanging fruits, was histoplasmosis in Africa. We have extensive data to show that histoplasmosis does occur in Nigeria. And I always tell the story that before HIV/AIDS became prominent in Nigeria, we had plenty cases documented. Then when HIV came, in the HIV population, none. Nothing in literature. So I said, histoplasma must have sat down with HIV virus and said, you know what, these are a miserable lot. So it's either you stay, I go, but the two of us can't coexist. So histoplasma took a stroll because there was no data. Okay, but does that mean it wasn't there? No. The clinicians were not looking. one of the challenges with histoplasmosis is that it presents like TB. And you know, TB is so common. In the African continent, if it walks like TB, it smiles like TB, it must be TB. If it's gene expert negative, it is treatment smear negative TB. If the patient had been on treatment and gene expert is not negative, but it's not doing well, it's treatment failure TB. And we feel good and we go to bed at night because we made a diagnosis. If it's a wrong diagnosis, well, we don't know. So we are like the ostrich, we are happy, we did something. Next slide, please. So we came up with this map that shows the distribution, and as you can see, so it doesn't like me again. If you can see up there, Nigeria, the beautiful country there, is estimated to have one of the highest rates. But like I said, none in the advanced HIV disease population, despite having a significant number of the HIV population on the continent. Next slide. So we wanted to find out, is it true that histoplasma sat down with HIV and said, you go, I stay, or? Because where is it? So we, first of all, investigated to find out if it is true. And we did this skin sensitivity testing. It's just like your MAN2 test, but it's for histoplasma. And we're able to prove that, yes, histoplasma was in Nigeria. Somebody just wasn't diagnosing it. Because we had wide geographical report numbers, variations in the numbers, but we definitely had positive histoplasmin skin sensitivity testing. Next slide, please. So we could say conclusively that it's not an emerging disease, it's a neglected disease in Africa, and particularly in Nigeria. And that we need clinicians to have a high index of suspicion. If not, every single one of these cases will be TB. Next slide, please. So, it presents almost like TB. Patient has cough, fever, productive of sputum, general feeling of not being fine. Everything, it just mimics TB. So there needs to be that index of suspicion on the part of the clinician. But also the diagnostics need to be available. In the African continent, we do not have facilities like Dr. Mohammed was talking to us about. How many facilities have biosafety level 3 labs? And you need to use it to make cultures. But however, next slide, please. WHO has said we could actually use, next slide. Okay, go back. WHO says we could actually use the urinary antigen test in the advanced HIV disease population. And this test is affordable, but no one was using it as of then. So histoplasma and HIV does coexist. We do know that there's extensive data from South America, but we lacked data in the African continent apart from case reports. There had been a study, I think, from Tanzania, but I don't know, the test then maybe wasn't so great, and then they looked at a very wild population. And we know that in 1987, histoplasmosis was classified as an AIDS-defining disease. Next slide. And then in children, in the African children, we looked at this in literature and discovered that it's not even HIV that drives it in children. You have children with a lot of other diseases. Histoplasma can be easily misdiagnosed as anything, from tumors to malignancies to other infections. So it is critical that we have the diagnostics on ground so that the right diagnosis can be made. It's not just TB. It can be so many other things it can be misdiagnosed as. Next slide, please. So for the advanced HIV disease population, and I think from the work GAFFI also did actively, WHO adopted the urinary antigen test as a recommended essential diagnostic. And we thought when it becomes recommended, people that have patients, countries with patients with advanced HIV disease, a significant advanced HIV disease population, should at least screen this population. Okay? And we then went ahead to do screening in our own country. Next slide, please. With this screening, both in the HIV population and non-HIV population. And here we looked at, in this study, we looked at patients that were categorized as smear-negative TB or treatment failure TB, and we're looking for histoplasma in them because it could have been TB, or it was not. Some of them were sputum positive, GeneSPAT positive for TB, and we found a significant proportion of this patient actually even had co-infection, okay? And this test was done using both the urinary antigen test and the PCR. The next slide, please. And then when we looked at strictly at the advanced HIV disease population, this was a targeted study that looked at patients that had advanced HIV disease, but looks like they also had TB. So they must have at least 2-3 symptoms suggestive of TB. So it was pretty targeted, and we had a 7.7% prevalence, and then we had co-infection of about 9 patients having both TB and histoplasmosis, meaning if you started treatment for TB and patient wasn't getting better, you have a responsibility to look out for the possibility of a co-infection. It's not necessarily treatment failure TB. Okay, next slide, please. So on the basis of that data, we decided that we needed to build capacity in country. Because we have a significant, we're supposed to be a high, among the 22 high-burden TB countries. And we wonder how many of these TB cases were histoplasmosis or co-infection with histoplasmosis. So we went ahead to build capacity. One of the things we do when we build capacity is that we don't build capacity just for lab or just for clinicians. We build capacity for both, and then we provide diagnostics for them going forward. Because if the diagnostics are not there, building capacity is just talk, cheap talk. Okay, so we did this across 10 sites in Nigeria, built capacity in the lab, and then among the ART clinicians. Next slide, please. Okay, so these were part of the outcomes of the training. We discovered that we had positive cases. One is a good story, the other one is a bad story. It's there in literature, you could go check it out. One did very well, and the other died, okay, in the advanced HIV disease population, and that's a preventable death. The challenge why we had this patient die was because our result came out late. This second patient, the one below, had been managed for TB for 2 years. They just kept restarting treatment. But when we went through the case note, at no time was the patient GeneSPAT positive, had productive sputum, had skin lesions, and was managed as TB. So by the time we started the program and the urine sample was screened, it was positive. We went to, but because we're using the ELISA kit, we have to pull samples. And that took like about 2 weeks. By the time we went, the patient was dead. And I can assure you we'll count them as one of the TB deaths. Next slide. So recently we started fungal disease surveillance in country. And what we did was that we built capacity in that we looked at patients that we looked at, if you can see, this was in 2020 and 2021, and we collected sample. We looked at the lab registers to see how many samples were sent, how many organisms were identified. And in 2020, these are big tertiary hospitals in Nigeria, in quotes. Okay, the first one has a bedside of about 760. The second one has a bed size of 1,400, and the third one a bed size of over 500. But you could see that very little samples go there. These clinicians weren't sending samples, and even when they do, they got most of it were samples for skin, okay, for superficial infection. They weren't asking for. So we went ahead, we built capacity, we did trainings. Go back, please. We did trainings, and you can see that in the same period, over the same period, after the trainings, both in the lab and in providing diagnostics after the training, we had over 300% increase in samples that are sent. And we have more tests now being done. So more lives are being saved. Next slide. And I always like to end with this slide. If a clinician looks at that slide, can you go back? I can assure you, the clinician will think this patient has TB. So what I do is I send the slides to radiologists and say, please, I just saw this patient, can you help me? And always comes back as TB. Thank you.
Thank you very much, Rita. I think if we have two key messages that we can take from your presentation, the first would be that Nigeria left from an erroneous no case of cryptococcal meningitis to thousands of cases after implementing, to hundreds of cases after implementing training of clinicians and laboratory technicians. Then the second take-home message is that in front of an HIV patient, if you think TB, think histoplasmosis. But now, how do you think histoplasmosis if you don't have the test available? That is an opening to the next part of our program, where we want to invite some panelists to tell us, with all the information that has been shared this evening, and based on your experience as those who are decision makers and those who are hands-on in our different ministries of health, how do we take it from here? So I'll start by inviting Dr. Lamboli Kumboneki, who is a senior program officer for HIV in the Southern Africa Development Community. Dr. Lamboli, you can come to the panel. The next person is Dr. Moutes Bila, who is our Africa CDC focal point for Tunisia. You're welcome. Then, Rita, given the eloquence of your talk, can you join us to share your own experience with us? And last but not least, I would invite Dr. Nafiisah to also join the panelists. And I had about 15 questions for you. But for the sake of time, and looking at how comprehensive the presentations have been, maybe instead of asking a question, each panelist should give us a summary of what they think together. By the time we leave this hall, what can I or she start doing tomorrow to ensure that we reduce mortality associated with fungal diseases? I'll start with you, Dr. Lamboli.
The first point I would like to mention here, I think in summary, we've seen that we've got three important points actually. The first is about the lack of sensitization. Sensitization is mainly at different levels, at the decision makers level, at the clinician levels, but also when it comes to implementation of those different strategies and tools which are available, but we are not looking at them. I think there's also a very important examples that we've seen among the data and the result of the studies. When we look at the result of the studies, you'll see that you've got different results as far as histoplasmosis is concerned. You have a different result for cryptococcal meningitis and also for aspergillus, I think also. But when you are looking at first cryptococcal meningitis, I think the table has shown that when you look at the countries in the Eastern and Southern Africa, there's a good coverage. This is mainly due to the fact that you have a strong link with HIV, and we all know that the Eastern and Southern part of Africa is the most affected by those diseases. So there's been a lot of talk, a lot of sensitizations at the highest level, which has led the countries to invest into diagnosis cryptococcal meningitis. Hence, we've seen that most of them appear in green. But when it comes to histoplasmosis, we are not seeing the same pictures because there's also a lack of sensitization, which just Dr. Rita talked about. And also, there's no much information at the highest level. And the last part also, we have got the same information when it comes to the aspergillus in the different parts of the continent and also in Africa.
But now, what is the most important message that we can get from this, all this information that we've got here? I believe the first step should be for us to increase sensitization. Sensitization should start first with the clinician, to be sure that I think the Guatemala example and also the Nigerian example are a very good example. We don't have to reinvent the wheel. We need to copy and see what we can do best. How can we customize it into the context of our different countries, but also increase that sensitization and train more people. When it comes to availability of the different reagent, and also making sure that the political environment, the legal environment in terms of sustainability, even after any other type of intervention through the donors, we should still have the government to take it on board, and making sure that we have those different tools available at our level. It's important also to bring now the different government in place, and making sure that it's part of the priorities. And from at my end, I would say, when you look at also most of the guidelines, when it comes to HIV, you'll notice that you have that sections on cryptococcal meningitis, mainly histoplasmosis, which is less spoken, and also aspergillus, where maybe they reserve half of a page to those diseases to discuss about it. But it's also an issue now, saying how do we integrate it, how do we increase awareness about those diseases, and also putting it now at the highest level. I would say, naturally coming from a more or less a political environment, which is the Southern African Development Community, to put it at the highest level, at the ministers level, who can discuss it and see the importance. I think someone at the beginning has mentioned a very important point. When you discuss with ministers of finance, you need data. It's not only ministers of finance, even ministers of health, different ministers, head of state, they need data to see that, look, we have 1.1 million of people who are suffering, who are at risk of death and of those different fungal infections on the continent. This is what we need to do, and what is the impact on the economy, on productivity, and so forth. So let's have a multi-pronged approach, which is targeting the decision makers in terms of the political level. Let's also increase that awareness at clinical level to ensure that we are aware of, we know that we have to look for those diseases and those infections when we have a patient, especially when it comes to HIV, when it comes to cancer. And also let's make sure that we implement those different guidelines and the tools which are available within the countries and also the continental level. Thank you.
Thank you for the invitation, and I'm so happy to be here with you. My intervention is going to be in French. I'm sorry about that. D'un point de vue, parlant de l'expérience de la Tunisie, en fait, venant de la Tunisie, je pense que l'échange de compétences avec les pays membres, c'est très important, et on doit mettre l'accent sur le développement de compétences, comme l'expérience de la Nigeria, dans le cadre de développer et former les techniciens de laboratoire et former les biologistes dans le cadre de diagnostic des maladies fongiques. C'est très important, et cela, je veux mettre l'accent aussi sur les tables rondes et les événements de témoignage avec les experts de tout le continent, pour pouvoir y avoir un retour et un feedback des expériences de terrain. L'autre point que je voulais vraiment mentionner, c'est les laboratoires actuellement, regardons les statistiques un peu partout en Afrique, il y a des datas qui ne sont pas disponibles, et il y a aussi un manque des équipements, et un manque aussi des professionnels de santé qui sont spécialistes dans la mycologie et la parasitologie. Nous, par exemple, en Tunisie, on a des laboratoires qui sont spécifiques et de prélèvements fongiques et prélèvements mycologiques. Il y en a des unités de recherche qui sont dédiées à cela. Donc, j'encourage de vraiment échanger et avoir la possibilité de, c'est-à-dire de l'échange des compétences et des expériences, voilà, pardon. L'échange des expériences et des témoignages avec les experts un peu partout en Afrique et des pays membres, et surtout mettre l'accent sur la recherche. C'est ça, c'est mon point de vue, la formation et l'échange avec les experts qui sont un peu partout en Afrique. Et je sais très bien qu'il y en a des pays qui sont vraiment leaders en termes de recherche fongique et mycologique dans les laboratoires, dans des unités de recherche. Voilà, merci. Et si vous avez des questions, je serai ravi de vous répondre. Merci.
I think one of my takes from this meeting is it's glaring that strengthening of systems is important. We need to strengthen the system in that we need to put the diagnostics in place. But before we do that, we must build capacity. Because if you strengthen the labs and you do not build capacity with clinicians, there'll still be a gap. A typical example was when the crack test first came to my country. The first time it was brought to Nigeria was in 2013. And they distributed it in all the labs. And they expired in all the labs. Nobody requested the test because they assume you put it there and then nobody requested it. So they expired there. But now we're having challenges with stock out. Okay, so it's critical that we build capacity. It's critical that capacity both in the lab and among clinicians. And then it is critical that we provide the diagnostics, because if you build capacity and there are no diagnostics, it's an exercise in futility. With time, everybody forgets what they learned. So that is critical. Then most importantly, you know, he talked about research. It's time we start fungal disease surveillance in the African continent. We have where geographical our climate, everything is different. So we need to start fungal disease surveillance, but we can't start it without building this capacity. We could piggyback right on the AMR program going on, right? We want to look for low-hanging fruit, Candida, Aspergillus. Do we have resistance in this? We don't even have the drugs available. Do we already have resistance? And once we are able to generate that data, like he said, what the ministers and the head of state need are figures, not estimates. Figures. So we say, you see, we have this number and it translates to this. I love the way David projected that data. I'd seen that paper before, but I'd never really looked at it from the perspective of, okay, how many lives could have been saved? The deaths went down. I did see that graph. I didn't translate it to the fact that the deaths went down because capacity and diagnostics was provided. I thought fantastic screening program. The doctors started treatment right, but the drugs didn't change. So it is critical we do that. Thank you.
Thank you. So, wow, there's a lot that's been said. And I think everyone has said anything, so I will not, no, I'm kidding. I won't add anything. Je veux juste peut-être ajouter un commentaire, mais très rapidement, vraiment pour cerner un peu ce qui a été dit. Vraiment, on a eu énormément d'informations lors de cette session, mais peut-être vraiment pour résumer une ou deux choses clés et peut-être ajouter on top of that ce que j'ai remarqué. Je crois que une des thématiques qu'on a mentionné vraiment à chaque fois, c'est la formation, le renforcement des capacités, la formation. Et là, c'est vraiment, encore une fois, comme on l'a dit, et c'est même dans les réunions qu'on a eues avec les États membres, c'est quelque chose de clé qui a été mentionné à chaque fois. Vraiment, il faut former notre personnel de santé. que ce soit les cliniciens, que ce soit les laborantins, vraiment tout le monde. Mais moi, je voudrais même aller un peu plus loin. Je voudrais même dire qu'on devrait former les agents de santé communautaire. On devrait aller au sein de la communauté elle-même. Et je sais qu'au Nigeria, vous avez des journées de commémoration sur les maladies fongiques, si je ne me trompe pas. Fungal Disease Celebration Day. Et je crois que ça, c'est une idée fantastique. C'est déjà quelque chose qui fait que les gens disent « Ah, les maladies fongiques, mais c'est quoi? C'est un champignon? On peut le manger? C'est quoi ?» It triggers conversations. Ça commence la conversation, ça commence justement les gens commencent à réfléchir à ce qu'ils peuvent faire et ils commencent à réfléchir ils voient leurs collègues et eux-mêmes ils peuvent dire ah mais ça ressemble à quelque chose que j'ai vu et que l'agent de santé communautaire m'en a parlé et voici un pamphlet sur ça, tu devrais te faire tester ou aller à la clinique pour telle ou telle chose. Et ça, c'est vraiment, je pense que raising the awareness in the community, déjà, faire le plaidoyer au sein de la communauté, increasing the knowledge within the community, avec les agents de santé communautaire, avec le personnel de santé, avec les infirmières qui sont dans les CHU très proches de la communauté. Je pense que déjà, ça, c'est une première étape. Et ça, c'est quelque chose qu'on peut déjà faire. Et je mentionne ça, pourquoi? Parce qu'on a, oui, je sais, pardon. On a déjà un programme d'agents de santé communautaire au sein d'Africa CDC. Et ce qu'on est en train de développer, c'est vraiment un curriculum intégré pour faire en sorte que l'agent de santé communautaire soit formé sur presque toutes les maladies. Bon, je dis toutes les maladies, bien sûr, ça sera difficile pour la personne de travailler sur toutes les maladies, mais à la base d'avoir cette formation. Et on pourrait même ajouter les maladies fongiques à cette formation. Ah, j'entends la traduction, ouais, c'est pas grave. La deuxième chose, je pense aussi, c'est encore une fois l'accès au diagnostic. Je crois que c'est clé. J'ai regardé les cartes qui ont été partagées par David. Et vraiment, c'est insensé qu'on n'a pas justement on n'a pas accès à ces diagnostics clés, on n'a pas accès aux médicaments qui sont vraiment de base et qui est accessible dans le monde entier, excepté en Afrique. C'est inacceptable. Et c'est ce genre justement de choses sur lesquelles on peut travailler en tant qu'Africa CDC. On l'a fait déjà avec la Covid et on peut certainement le faire pour les maladies fongiques. Il y a d'autres, bien sûr, d'autres thématiques qu'on pourrait aborder lors de cette session, mais je crois que c'est les deux choses que j'aimerais quand même m'apaisantir dessus. Voilà. Merci beaucoup.
Thank you very much, panelists, for this conclusion. I think part of my task was to highlight the key messages that we need to take home. And one thing came out very clearly. We unanimously think fungal diseases are a priority, don't we? And if it's a priority, it needs to be spoken at every level of the community. Sensitization came up so many times, be it people in the community health workers, clinicians. We need policy makers. And I can assure you that if we are unanimous that fungal diseases are a priority, this should be among one of the things that should be discussed during the next summit with our highest political leaders to get their buy-in. Once this buy-in comes in, we have agreed that training is key. And Nafiisah brought up a point which is very interesting, community health workers. David, in your presentation, you showed clearly that we've got simple diagnostic tools. I want to challenge everyone in this room. When you go home, go on YouTube and tap cryptococcal antigen test. You don't need to be a healthcare personnel to do that test. So we can train people in the community to do triage, so that by the time this test is positive, they can tell you, go to the hospital and meet Rita for a lumbar puncture. Then we talked about the clinicians. These are the people. I mentioned that if you think TB in an HIV patient, also think histoplasmosis, think aspergillosis. Then the people who are supposed to provide these medications for us, please, when you go back home, on Monday, first thing, check whether on the essential drug list in Tunisia, we have antifungals. And if we don't have, it's the time that you should do something. We talked about research, evidence-based. I mean, Rita has shown with some data and then even the data from Guatemala, that if we don't prove it, then we have not done it. And to go a step further, politicians like to, they don't care how many percentage you reduce the mortality. They just want to know that $1 prevented 3 people from dying. Then it becomes interesting because you're talking in monetary terms. So we should also learn to make business cases. We talked about surveillance. The nice thing is that COVID-19 has created a situation where there's been a lot of investment in surveillance, pathogenomics. The question now is, after the COVID-19 is over, what becomes of all of those investments? How do we repurpose that and to be able to do surveillance of other pathogens that have outbreak potentials? We've heard about Candida auris outbreaks in South Africa. If we had a good surveillance system, maybe we would have picked that up before it became an outbreak. So in the repurposing of these systems, we should think about including fungal diseases. And we would never say it enough. Make sure that the tests are available. Availability should be to bulk procurement. We've got experience in that already with the COVID-19 vaccine acquisition, that the vaccine was negotiated for the whole continent. Why don't we do the same for fungal disease diagnostics? That is for the short term. Then in the long term, we should think about using all, Rita said, Africa is a melting pot where anything can thrive. If we make the diagnosis, we find some of these organisms, let's use them to locally produce our own tests to diagnose them. So, using my modest voice and speaking for all the people who did so much work for us to be able to summarize this data today and present it the way you see it, and to all the patients whose data was used to bring this to make this report, we want to celebrate them because they may have not or may not benefit from what comes out of this, but they have contributed enormously. And we want to thank them for providing a platform for others to be able to live without fungal diseases. So, on this note, we are officially launching the report on diagnostics for fungal diseases in Africa, a GAFFI survey 2022. Ladies and gentlemen, put your hands together for this.